Hello, welcome back to UWorld's Next Gen NCLEX review. My name is Samantha and I am a nurse here at UWorld. Today we are going to look into pediatric sicknesses now that school is back in session and our kiddos are back to school. Those colder winter months that we have coming up for us enable the quick spread of many childhood illnesses because these kids are in close contact with their classmates, with their peers. They're confined to mostly indoor spaces and they're sharing all of their school supplies, their toys, etc. Today we're going to highlight those common childhood illnesses of pertussis, of varicella or chickenpox, and of course RSV or respiratory syncytial virus. We've had a lot of requests for more pediatric content, and we want to make sure that we are delivering what you guys want to see and to hear and to learn about. So continue to let us know what topics you want to see. We have a lot more pediatric and obstetric and maternal health based content coming up for y'all in the very near future. Keep letting us know how we can best help you. After all, that's what we're here for. There will be questions peppered throughout today's video, as well as NCLEX style questions at the end. Today we have a special bonus question, so we have 3 questions instead of 2, so make sure you hold on so you can answer those. For your reference, this live will be on demand on both Facebook and YouTube, so you're always able to drop back in, use it as a study reference in the future, and as always, drop those comments, those questions, and those answers in the chat. Nurse Jackie is monitoring our chat for us today. She wants to hear from you guys. So to go off and get that chat started, let us know where everyone is joining from, who is joining us from here in the USA, who is an international viewer. Please let us know. I saw last week a lot of people from Nairobi, Kenya, and I saw some from Russia. It's so interesting to us to see where all our viewers are tuning in from. So let us know. Tell us a little bit more about yourselves. So while y'all type those answers in the chat, I'll go ahead and get started. We're going to kick off today's lecture with pertussis. So pertussis is a respiratory infection. I bet you've all heard of it before. It is caused by the Bordetella pertussis bacteria. And you may have heard pertussis referred to as a different name, a more common kind of colloquial name. So I'm going to drop a quick question to get us started in the chat today. What is the common name for pertussis? What is this common name that you may hear it referred to as people who are not in the medical world? So go ahead and drop that answer in the chat. What is the common name for pertussis? In the meantime, a reminder to follow us on our social media channels, share this live. We have a team of UWorld nurses that are here dedicated to putting content out for you guys. Here at UWorld, we're cultivating a whole nursing community that is so much more than just a one-stop test preparation shop. We are helping put out content that covers the full spectrum of the nursing lifestyle, from applying to nursing school, passing your nursing school classes, taking your NCLEX, and into those first few years of independent practice. So we really want to make sure y'all don't miss out on that. So make sure to follow us on whatever your preferred social media channel is. I'm going to go ahead and check the chat, and we have an overwhelming response today. You guys did so well. Whooping cough is what the common name for pertussis is. So y'all did so well on that. That's a good one to get us started today. So more about pertussis and the patho of pertussis. We have a great image here. Feel free to screenshot it as a reference for the future, but this is spread via droplets. So upon sneezing, coughing, even just talking with someone in close contact, this is how pertussis is spread. Bacteria in the droplets actually work their way into the client's airway, and here they're going to attach to cilia in the airway. Now cilia help to move secretions and different things throughout our airway, but unfortunately the bacteria will release toxins that immobilize that cilia. And the problem here is that it makes them unable to move mucus, to clear secretions. And what this is going to lead to is airway obstruction, airway irritation, and of course, airway inflammation. It also results in that signature whooping cough sound that is the hallmark of pertussis. So the clinical manifestations here, we can divide this into 3 different phases. The first is something called the catarrhal phase. It's the first 1 to 2 weeks of pertussis. And this is highlighted by a mild cough, rhinitis, which is that irritation of the mucous membrane in the nose. This leads to that nasal itchiness, that nasal runniness, similar to what you may experience if you have seasonal allergies. And we'll see sneezing, as well as low-grade fever. We then move on to the paroxysmal phase. Now, this is lasting from about week 2 to week 6 of pertussis. Here, this is where we're kind of getting worse. It's categorized by those extreme, and it can be extensive coughing attacks. The cough will be followed by an inspiratory whoop, again, the hallmark of that whooping cough. And it's really hard to breathe in these extensive coughing spells, especially for our pediatric clients. They can have such extensive coughing spells that they even have something called post-tussive emesis, which is where they're actually vomiting because they've been coughing so hard. Another potential side effect that is most commonly seen from pertussis in our pediatric clients is that apnea, or a period where they're not breathing, because of that immature pediatric respiratory system. So after we move out of the catarrhal phase, which we're kind of in the worst, most severe, highest acuity part of pertussis, we then move into the convalescent phase, which lasts from about week 6 to week 10. And here the good news is that we're getting a little bit better. That cough kind of works its way down to more of a mild cough, and it's going to gradually be resolving, but still important to notify these clients, and especially if it's a pediatric client, we're notifying their parent or caregiver that this cough can persist for 6 to 10 weeks, but it should be gradually subsiding. So our diagnosis for pertussis is going to be that nasopharyngeal swab, or that PCR. This is just like the COVID test, if you've had one of them, where they swab up your nose. As many of you probably know, it's pretty uncomfortable, and you can imagine a pediatric client will probably not take kindly to this, but this is kind of the gold standard of how we would diagnose pertussis. So our nursing interventions, what are we doing for these sick kiddos? So we are enacting droplet precautions. A reminder that droplet precautions are going to be that surgical mask, and we're making sure we're enacting proper hand hygiene, both for the healthcare team and making sure that our clients are washing their hands. We are enacting and making sure we have an order for antibiotics, and the sooner the better here. We're giving humidified air and increasing fluid intake, whether that be oral or via IV. And this humidified air, increased fluid intake really works to thin those secretions, which is going to make them much easier to expel and to cough up. So this is a super important step. We also are monitoring for signs of airway obstruction. Now, pediatric clients, sometimes when they're in respiratory distress, they're going to present a little bit differently than a full-grown client. And we do have a great image at the end of this presentation that we'll touch on later, but a couple things to just to kind of bookmark here. Retractions in the pediatric client is a key sign of airway obstruction. A key place that you can look for this is right where that rib meets the abdomen. You'll see kind of like a sucking in retraction. That's what it is. It can also be found in the neck as well as in between ribs. And you'll also see, especially in infants, restlessness can be a sign of airway obstruction. For an infant, we would typically use a bulb syringe to suction that mouth and the nares. And then as we move up and get a little bit older, we may be using like hooked up to wall suction, for instance. So this clearing these secretions is really going to help prevent apnea, which is such a common complication in our pediatric population. Also to note that stagnant mucus, if it's not being thinned and if it's not being expelled, stagnant mucus in your lungs and in your airway is a breeding ground for bacteria and viruses. It can lead to other opportunistic infection, and it can also lead to pneumonia, which is really what we're going to want to prevent. Alrighty, so client teaching. Important to note here is that depending on the age of these clients, they may or may not be able to really independently take care of themselves in our pediatric population. So we're making sure that we're incorporating a parent, we're incorporating a caregiver, and we're really assessing the client's, the pediatric client's education level and how much they're going to be able to absorb. So things that we're going to educate both the pediatric client and their caregiver on are things like avoiding triggers. So exercise, we're not going to want these clients to be out increasing their demand for oxygen. We're also going to want to make sure they limit their smoke exposure. I hope that these kids are not smoking themselves, but if, for instance, they live in a household where they're experiencing secondhand smoke, this is something we'd really want to make sure was far away from them. And we're also limiting their exposure to cold temperatures, because this again can trigger that airway constriction. So antibiotic prophylaxis may also be indicated for the household and family members just to help prevent the spread. And it's also, I think I brushed on this earlier, but we really want to make sure they know this cough can persist up to 6 to 10 weeks. So they need to know that if they do have a persistent cough, as long as it's getting better, it's not a cause for concern. And these clients will be considered contagious until they have completed 5 full days of antibiotics. So this is why antibiotic stewardship and really finishing that full course is so important here. there. So y'all did a great job on that subject matter. We can now move on from pertussis into varicella, or our chickenpox, as I'm sure you probably know it by. So this is a viral infection caused by the varicella zoster virus. Chickenpox is extremely contagious. I'm sure you guys already know that. It is spread both through airborne as well as direct contact with those chickenpox lesions. So I'm going to put a question out to the chat. Y'all did so well on the first one. I know you'll do just as well on this one. What is the difference between airborne precautions and contact precautions? So what do both of these require as far as the PPE that's required? I'm going to give you guys some time because this is a longer answer, and you don't have to get them both if you only know one. Absolutely no worries. In the meantime, I just want to remind you, go ahead and follow us on social media, share this live. We have a few more questions for you today, including those NCLEX style questions at the end. So make sure you're sharing it so everyone in your community can benefit from this information and these questions. Alrighty, so I'm going to go ahead and check the chat and see. Again, the question was what the difference was between airborne and contact precautions, and what PPE is required for either. Alrighty. So I see some great answers coming in already, and you guys seem to get this. I feel like that's the first week of nursing school. They really kind of hammer in the different precautions. But for airborne, we are using an N95 respirator mask that has been fit tested, and we know it's sealed to the face. And always the door must remain closed to the client's room. And in contact, we are gowning up, gloving up, and making sure we are enacting proper hand hygiene. It's also important to notice that any of these precautions, especially contact precautions, that equipment must either be disposable equipment or it must be left in the client's room for the duration of their stay and then sanitized prior to going back out into a main population area. So important to remember. Let's look more into what varicella actually is, what these clients are going to be experiencing. So these clients are contagious 1 to 2 days prior to the rash appearing, and they're contagious all the way through. All of their lesions have crusted over. So the lesions have 4 stages. They start out in the maculopapular phase, which is a flat red demarcation on the skin. They then transition into the vesicular phase. And remember, a vesicle is anything that carries something else. So in the vesicular phase, they fill with fluid and they become raised from the skin. We then move on to the pustular phase. As you can probably assume, at this point, they fill with pus, they become more opaque, and again, they're still raised from the skin. And lastly, we have the crusting phase. The crusting phase only occurs once the vesicles have popped and the fluid has drained. And at this point, it's important to notice that these, when they're open, are a huge risk for infection, but they'll only be open for so long before they crust over. And a reminder that only after all lesions on all parts of the body have crusted over is the client no longer considered contagious. Alrighty, so there is a vaccine for chickenpox. I hope you all have gotten it. However, it's an active vaccine, so it's only going to be available after that child turns 1 year old. And the clinical features of varicella, this is going to present like a common cold. A lot of our respiratory illnesses, whether they're bacterial or viral, will really present like a common cold. We'll have a low fever, a cough, fatigue, that signature kind of loss of appetite, that really not wanting to eat much. And then the rash will start to set in. So it starts out, again, that maculopapular, that flat red demarcation on the skin. It's itchy, and it typically begins on the trunk and the face, and then later spreads to our extremities. So it usually takes about 1 full week for these lesions to go through the full range from maculopapular to vesicular, pustular, and finally to that crusting phase. Alrighty, so let's look at our nursing interventions. What can we do to help these clients? These chickenpox are so itchy, they're uncomfortable, but there's a couple of things we can do to make these clients, specifically our pediatric clients, just a little more comfortable. So the first thing we're going to want to keep an eye out for is preventing secondary infection. Again, when these vesicles pop and they're open, they are a huge infection risk. So we're doing things like keeping the area clean, making sure these clients are enacting proper hygiene, they're showering or bathing frequently. We can also give an oatmeal bath to help soothe this damaged, dry, itchy skin. And we're doing things like keeping the fingernails short. Those long fingernails are abrasive, and when these clients scratch, they can pop more of these vesicles open, they can damage their skin, and fingernails carry a lot of bacteria. So this is a huge risk to infecting these open lesions. For a younger client that maybe isn't able to understand direction not to scratch, we may have to put mittens on them them, especially while they sleep. And this will help minimize scratching and, most importantly, minimize damage from the scratching. A soothing lotion like a calamine lotion can also provide relief to these kiddos. So we may be doing that on all of their lesions just to give them a little bit of relief. Alrighty, so management in a hospital case, if there's kids are coming in, we of course would be enacting our airborne and our contact precautions. Any immunocompromised child may need an additional antiviral like an acyclovir. And it's also important, as we brushed on earlier, these children need to be isolated until all their lesions have crusted over. So y'all did so wonderful on that section of our lecture content. Let's go ahead and move on to RSV, respiratory syncytial virus. So as you probably know by now, RSV is caused by a virus. If anyone's ever been in a pediatric ER or a children's hospital, if you go at the time when it's a little bit colder in our winter and our spring months, these hospitals are absolutely filled with RSV kids. So what RSV causes is inflammation in the bronchioles of the lungs, something called bronchiolitis, and a thick mucus production. Those are kind of the two hallmarks. So that inflammation of the bronchioles, we can start there. This is something called bronchiolitis, and this is most commonly caused by RSV. So when you see these two, I always want you to kind of link them together. One can be a cause of the other. So if you see that on a question, don't be surprised. That might be a little bit hint for later. So this can result in difficulty breathing. It's transmitted through direct contact. So of course, we're going to want to have our gown and gloves, or droplet, which means we would have to put on our surgical mask. It is most commonly spread in the winter, in the spring, in that cold and flu season. Again, in those colder months, people are pent up inside. They're not getting outside. They're close by. They're household members, family members, and this only enables the spread of RSV. Our diagnosis, again, would be that nasopharyngeal swab, as unpleasant as it is. We're using a PCR swab, just like COVID, just like pertussis. So there are some key risk factors of RSV, and typically the biggest risk factor here are children under 6 months of age. Again, these kids have really an immature respiratory system. They're not able to have those strong lungs that can cough and expel secretions, so they're at a really high risk. Not only are they at a risk for having complications such as pneumonia from RSV, but they're also at a risk for contracting the most severe cases of RSV. As well as a child with an underlying pulmonary disease like an asthma or a cystic fibrosis, we also are more likely to see an RSV in a client like that. Anyone, no matter the age, who is immunocompromised, or anyone who smokes or is consistently exposed to secondhand smoke exposure is also a risk factor regardless of age. And we typically see some of our older, like geriatric clients are also likely to come down with RSV. Alrighty, so clinical features. Again, like I told you, it's most commonly in our infants, in our children, but it's not just affecting those under 6 months. It can also affect the immunocompromised and our older population specifically. In the initial stage of RSV, just like our other sicknesses, it does typically present like that common cold, those icky, the rhinorrhea, the runny nose, the cough, pharyngitis, which is the inflammation of the pharynx, which essentially just causes a sore throat, and sneezing, as well as fever. So upon auscultation, when we're listening to these clients, we may hear like wheezing and crackling lung sounds, and typically RSV is going to last from 7 to 10 days. But it's important to note that around day 5 is really where it peaks and when it gets most severe. And days 3 through 5 is when these pediatric clients are most at risk for needing hospitalization. So a key teaching here for the parents of these pediatric clients is teaching them when this case can be managed at home and when they need to seek medical attention. So there really are 2 red flags we're going to brush on here. It's a red flag that this client, this kid, this infant needs to go to a children's hospital and seek medical attention. And those 2 red flags are going to be increased work of breathing, which can include like a grunting, the use of accessory muscles, retractions, nasal flaring, as well as apneic periods. And those apneic periods are really, really common in infants with RSV. This essentially means that they're breathing really heavily for a period, and it's followed by a period of up to 20 seconds where they don't breathe or they breathe very seldomly. Again, we're going to go over signs of respiratory distress a little bit more in depth at the end of today's presentation, but increased work of breathing and apneic periods are going to be our red flags for this kid needs to go to a hospital. So our nursing interventions say that this kid does need to go to the hospital. They've been exhibiting some of these red flags. What are the nurses and the doctors going to be doing for these clients in a clinical setting? We, of course, are enacting our contact and our droplet precautions. We are administering IV fluids. We're giving them oxygen if their saturation dips below 90%. And we're probably giving a Tylenol or an acetaminophen if they do contract a fever. We'll suction as needed for those little baby and those young child lungs. They're not always strong enough to cough up those secretions, especially those thick secretions that are so common in RSV. So we're going to give them a little help out there. We're also going to closely monitor intake and output. We're going to assess for signs of dehydration. We're going to give them fluid to help thin those secretions, whether it's IV or oral. And we're just going to do everything we can to thin out these secretions, make them easier to cough up, and suction out whatever they can't cough up. We also want to closely monitor activity level. Some of these clients are so young, they're not able to advocate for themselves when they're not able to breathe, when they're not feeling good. So we're going to keep a close eye on if they're becoming listless or lethargic, because this can be a key sign of decompensation in a child or an infant. We're also preventing additional infection. Those thick secretions, again, I think we brushed on this earlier, but those are so just a breeding ground. They're absolutely like a party for different bacteria and viruses, and we want to make sure they don't contract an additional opportunistic infection like pneumonia. Alrighty, so as promised, we're now going to touch on the signs of respiratory distress. We have a great image for you guys. Go ahead, screenshot it. I think this is something that's really going to help you in your pediatric classes. I think the biggest issue when it comes to pediatric populations, so much of what you see in a hospital-based system is going to be respiratory issues. So knowing the signs of respiratory distress can really help you in a clinical setting as well as an NCLEX setting. So signs of respiratory distress, tachypnea is going to be a key one here, that increased rate of breathing. They can be grunting. Infants sometimes can be a little bit spitty too around the mouth. We can see retractions. In key places that we see, again, they're going to be where the rib cage meets the abdomen, that kind of like sucking, pulling in. It can be in the outline of the ribs as well as even in the neck, kind of where that clavicle is. So these are key to look out for. If they're using accessory muscles, so they're kind of using their whole body to breathe because their lungs are just working so hard without a lot of payoff. We'll also see hypoxia and things like nasal flaring, so those nares will get big and dilated to help breathe more air in. And things that we can do to help here are sit these kids up at a 30 to a 40 degree angle. Also administer high flow nasal cannula oxygen. And we can warm and humidify this oxygen, not only to make it more comfortable for the client, but this warm air is going to help open up our airway, and the humidification is going to help moisten and thin out that mucus. So you guys did so well. We are now all the way through our lecture content for the day, and we're going to move on to our question section of today's lecture. So our first question is a priority question. So the nurse is caring for a 6-month-old client who has bronchiolitis. It would be a priority for the nurse to monitor the client for: Number 1, decreased urine output. Number 2, nasal flaring. Number 3, changes in appetite. And lastly, number 4, fever. So remember, in a priority question, we may have more than one answer that is correct that we would do, but there's going to be one that's a priority that's a little more important that we need to address sooner than the rest of the options. So I'm going to give you some time, drop your answers in the chat, and a reminder that we go live 3 times a week, Tuesdays, Wednesdays, and Thursdays. On Tuesdays, we are at 12 p.m. Central Time. That's today's content. It's a lecture-based content with a few questions sprinkled throughout. And then Wednesday and Thursday, we're focusing on NCLEX style question drills, and Nurse Jackie will be putting those on for us. So I'm going to go ahead, and I hope you guys join in for those. I'm going to check the chat and see how we're doing, and you guys absolutely in spades got this. I see almost completely option 2, which is correct, nasal flaring. So again, bronchiolitis and RSV are kind of going to go hand in hand. RSV is the major cause of bronchiolitis, and a priority here, nasal flaring is a sign of respiratory distress. We just covered this in the slide above. So nasal flaring is going to be our priority to monitor for, because this means that the client may be decompensating, they may be having severe respiratory distress. So way to go, and you guys got it to your ABCs, airway, breathing, circulation. This would be airway, that A in ABC. So let's move on to question 2. Y'all did so well on that one. Let's see if I can stump you with this one. So the nurse is caring for an infant with a respiratory syncytial virus, RSV. Which of the following findings would the nurse expect to observe? Select all that apply. So 1 is fever, 2 is tachypnea, 3 is poor feeding, 4 is sunken fontanelles, and 5 is excessive mucus production. So remember, select all that apply. We'll have more than one correct answer here. This is a longer question, so take your time to read it. And go ahead and drop any topics or any body systems that you guys want to see us cover more of. We are here to help you guys. Let us know how we can best do that. Like I said, the pediatric and the OB content we have coming at you guys was requested by some people that had previously viewed our lives. So we're always interested to hear what you guys want to see, what you want to learn more about. Don't be shy. Let us know. We do take your recommendations into consideration. All right, I'm going to head back to the chat and see how y'all are doing. So I see, okay, mostly a combination of the correct answers. We have a few things that vary here, but our correct answers here are going to be option 1, 2, 3, and 5. So fever, tachypnea, poor feeding, and excessive mucus production. So we are talking about RSV here. We know that fever, that tachypnea, the increased rate of breathing, poor feeding, they're gonna have a loss of appetite. And this one, it's an infant, so infants, what they're feeding, how well whether they're taking a bottle or they're breastfeeding, that's going to be a key sign of kind of their appetite. And then excessive mucus production, that one is a hallmark of RSV. If you put number 4, and I don't see a lot of them, sunken fontanelles in an infant are typically a sign of dehydration. This can occur in RSV, but it's more so a complication of RSV that happens further down the line and requires further intervention rather than something that a nurse would initially observe. So if you put 1, 2, 3, and 5, you got it right. I see mostly correct options. Way to go, guys. You did so well on that one. All right, our last question, our bonus question today, this is a plan of care question. So the nurse is caring for a client with varicella who has open lesions. Which of the following infection control precautions, should the nurse implement? Number 1, wipe down all surfaces with bleach before exiting the client's room. Number 2, place the client in a semi-private room with a client who has pertussis. Number 3, limit visits by the client's family members to 1 30-minute visit per shift. And 4, put on an N95 respirator mask, protective gown, and clean gloves before entering the client's room. This one's a little bit longer. The answer choices are a little bit longer, so I'm going to give you guys more time. So go ahead, and a key thing here with any NCLEX question, the number one reason for mistakes, I feel like, is people not adequately reading the full question, reading all of the answer choices in depth, especially for longer questions. That is so, so important. So please take your time. And a reminder to follow us on social media. We are putting out nurse life content, which essentially it covers the full spectrum of nursing specialties. I talked about this a little bit at the beginning of today's lecture. We have some additional videos that just dropped last week and I believe 2 weeks before that. We're talking about the NCLEX test day. We're talking about testing anxiety, really key things that are so important to the nursing journey. So make sure you check those out. We don't just want to be an authority on, lecture content and test prep. We also want to be able to give you guys advice and tips and tricks on the actual journey of becoming and being a nurse. All right, so let's go ahead and pop back to the chat. And per usual, you guys are doing so well. Our correct answer is number 4. Put on an N95 respirator mask, protective gown, clean gloves, before entering the client's room. Varicella is always going to be airborne precautions, and if they have open lesions, which this question specifies they do have open lesions, they would also be on contact precautions. So that N95 respirator is going to go with airborne, and our glove and gown are going to be along with our contact precautions that we are always keeping in place with these varicella clients with open lesions. So way to go, guys. You did so well on the questions. We have a schedule slide for you guys. It's a little different this week because we are having a wonderful events page that actually shows you our content for the next 3 weeks, and it allows you to enter your name and your email so that you can plug it in and get an email to your inbox every day, or every week, that tells you what we're going to be doing. On Wednesday, we're going to have a perioperative question drill, and we'll be back on Thursday with a pharmacology question drill. Pharmacology has been heavily requested by you guys, so I hope you'll tune in for that one. Thank you so much for tuning in today. I hope you found this to be helpful. Now that kids are back in school and those colder months are very close, they're near, they're coming in, these childhood sicknesses are becoming an increasing issue again, like they do every year. Children and infants can present so differently than our adult population, so I'm glad we did a pediatric specific lecture today. And it's important to note that older populations, as well as the immunocompromised, as well as really any adult, can also catch these viruses infections. They're not just for kids, but we just focused our content today on the pediatric population. So y'all did so wonderful. Way to go. A reminder that these lives will live on demand on both Facebook and YouTube for your future reference. Join us tomorrow at 3 p.m. Central Time too for a question drill. Thank you so much for joining, and I hope to see you guys next time.